Yeah, starting. Okay. Yes, students, welcome to our yet another session on pediatrics. The topic for today is nutrition. Almost all entrance paper as well as Viva OC, not even in Viva OC, but also in stations. You have a separate station for nutrition, you have a separate station for instruments. We are going to cover all those things, okay, in our pediatric session. So, as far as the nutrition is concerned, you will be given a great importance, right, with respect to whether it is a fat soluble vitamin, water soluble vitamin, severe acute malnutrition, or any other thing. Okay, right. So, let us watch on this nutrition topic right now. Right. So we are going to discuss about mainly fat soluble vitamins A, D, E, K, severe acute malnutrition, marasmus and kwashiorkor along with the breastfeeding for today's topic. But definitely they will be asking so many questions on vitamin A, either in essay question or in the stem of the question with the help of any entrance oriented question, and they will be asking about program related to vitamin A deficiency. So vitamin A deficiency is essentially a large essay question. So in order to tune you before going to this topic, let me show you four clinical pictures. So what are all those four clinical pictures? So you could see the one on the left hand corner. So what is this? There is a triangular opaque area in the conjunctiva. Triangular opaque area in conjunctiva. So what is this? You all know that it is known as Bitot spot. It is known as a Bitot spot. Triangular opaque area in the conjunctiva is called as Bitot spot. So what is this? Second one is conjunctiva. So first one is Bitot spot. Second one is, look at this. There is xerophthalmia, dryness of cornea. First it involves conjunctiva, then it involves cornea, then comes corneal ulcer. Then comes corneal ulcer. So xerophthalmia, corneal ulcer, Bitot spot are not only the manifestations of vitamin A, but also you have some of the skin manifestations. So what are all the skin manifestation? Perifollicular keratosis. Perifollicular keratosis. Because vitamin A helps in the formation of maturation of keratin. Whenever you have vitamin A deficiency, excess keratin will be accumulated around the hair follicle and it is called a perifollicular parakeratosis. Perifollicular hemorrhages occurs in case of scurvy or due to vitamin C deficiency. Right. So these four pictures, in order to make you to come into this topic, that is why we have shown this all these pictures. Okay. So what is this? A rough skin goosebump like appearance? What is this? Can anyone tell me what is this? If you have a rough skin goosebump like appearance in the elbow area, what is this? That is called as, can anyone tell me what is this? Todd like skin. What is this? Rough skin goosebump like appearance. Dark adaptation, defective dark adaptation, nyctalophia. nyctalophia or night blindness. Nyctalophia or night blindness. Dry hyperkeratinized ocular epithelium, conjunctival xerosis. Silvery foam like skin lesions on conjunctiva is called as Bitot spot. Bitot spot. Severe corneal xerosis leads to corneal ulcer. Increased susceptibility to systemic infections, particularly measles. Measles in turn can provoke to vitamin A deficiency. Vitamin A deficiency can predispose to measles. Measles itself can predispose to vitamin A deficiency. People must be thinking that the purpose of giving vitamin A supplementation in case of measles is to reduce night blindness. No, it is not so. Okay, no, it is not so. It is also to reduce the overall morbidity and mortality in measles. So, it reduces overall morbidity and mortality. Overall morbidity and mortality. What is this rough skin goosebump like appearance? This is called phrenoderma. So, two skin manifestations are, one is phrenoderma, another is perifollicular hyperkeratosis or parakeratosis. Other things are nyctalophia, conjunctival xerosis, Bitot spot, corneal xerosis, predisposes to measles, and also it reduces overall morbidity and mortality. So, conjunctival xerosis, Bitot spot, corneal xerosis, corneal ulceration, okay, and then corneal ulceration more than 1/3. So, these are all the various, what are all? These are all the various conjunctival xerosis, X1A, 1A, so Bitot spot, X1B, okay, corneal xerosis, xerophthalmia 2, and then corneal ulceration X3A, and then corneal ulceration more than X3B. X stands for xerophthalmia. And then you have xerophthalmia night blindness, xerophthalmia fundus, and there is xerophthalmia scarring. These are all the manifestations of vitamin A deficiency and classification of vitamin A deficiency with respect to eye. Okay, right. Now let's come to the treatment point. What is the management? Oral vitamin A less than 6 months is usually 50,000. How much? 50,000 international units. Okay, between 6 months to 12 months it is 1 lakh international units. And more than 1 year it is 2 lakh international units. How you need to give? Day 1 first dose, day 2 second dose, and day 14 third dose. So dose 1, dose 2, dose 3. So this is the therapeutic management of Bitot spot. And then your corneal conjunctival xerosis and then corneal xerosis. But for corneal ulceration, you need to give aqua solution of vitamin A in intramuscular injection rather than going for oral vitamin A, because oral vitamin A takes some time for its action to occur. So in case of corneal ulceration and xerophthalmia, better to start intramuscular administration of vitamin A. I repeat, for xerophthalmia, you need to give intramuscular injection of vitamin A rather than going for oral vitamin A, because it takes some long time for its action to occur. By this time, if you postpone, it will lead to severe night blindness. As a result of which, I repeat, xerophthalmia involving cornea should be treated with intramuscular administration of vitamin A. Okay, parenteral administration of vitamin A is also can be done in cases associated with the severe vomiting or malabsorption, because it will not be absorbed. Corneal involvement, as I told you already, requires emergency care with parenteral vitamin A rather than oral vitamin A, along with eye padding to prevent eye ulcers, and antibiotic eye drops should be given. So, what is the dietary management? Consumption of vitamin A rich products in the form of, mainly all of you know that carrot contain, leafy vegetables contain, dairy products as well as liver. Okay, right. So, what is the National Vitamin A Prophylaxis Program? National Vitamin A Prophylaxis Program includes giving 1 lakh international units of prophylactic even without signs and symptoms of vitamin A. So prophylactically, you will give 1 lakh international units at 9 months, followed by 2 lakh international units. 2 lakh international units at 15 to 18 months, along with the DPT booster. With DPT booster. So apart from 18th month, you will give a 24 month, 30 month, 36 months. 24, 30, 36 months. Okay, every 6 months you are giving. Every 6 months you are giving. 6 months you are giving vitamin A till the child has attained 5 years. Attained 5 years, right? Malnourished children should be treated with measles. Should be treated by giving vitamin A and preventing measles. So less than 1 year you give 1 lakh international units. More than 1 year you give 2 lakh international units. Apart from that, some other points that you need to know are what are all the other points you need to know? Other points that you need to know are, what is this? Excess vitamin A. Excess vitamin A can lead to toxicity. Can lead to toxicity because all of you know that it is a fat soluble vitamin. Anything that is fat soluble will be staying in the body for a longer period of time. So excess vitamin A can lead to acute and chronic. Acute leads to pseudo tumor cerebri, a raised intracranial like a picture, whereas chronic, so this one is acute vitamin A, whereas chronic hypervitaminosis A can lead to hyperostosis, thickening of bones, can lead to hyperostosis, hepatosplenomegaly, alopecia, etc. So alopecia, hepatosplenomegaly, hyperostosis are the manifestation of chronic hypervitaminosis, whereas acute hypervitaminosis is characterized by raised intracranial tension and it mimics pseudotumor cerebri. One cause for pseudotumor cerebri is excess vitamin A administration, so that you need to be very careful while giving vitamin A to the children, right? So what are all the things that you need to know with respect to vitamin A? And also in biochemistry you will be asking some questions with respect to visual cycles, that rhodopsin, those things will be asked in biochemistry. Okay, that visual cycle, dark adaptation and light adaptation will be asked in biochemistry topic. So as far as pediatrics is concerned, what are all the 5 manifestations of vitamin A? One is, what is this? Phrenoderma, perifollicular keratosis, bite spot, conjunctival xerosis, xerophthalmia, corneal ulcer less than 1/3, corneal ulcer more than 1/3. And with respect to signs, primary signs and secondary signs, these are all the WHO signs. So what is the management? What is the prophylaxis? What is the manifestation of acute hypervitaminosis? And what is the manifestation of chronic hypervitaminosis? These are all the questions that you will be facing in your Viva OC. Remember, acute hypervitaminosis, pseudotumor cerebri, increased intracranial tension in the form of headache, vomiting, sunset sign, everything. Whereas chronic hypervitaminosis is characterized by hyperostosis of bones, hepatosplenomegaly, and then alopecia. These are all the things with respect to chronic hypervitaminosis A, both acute hypervitaminosis, chronic hypervitaminosis, WHO classification of vitamin A, vitamin A prophylaxis, vitamin A treatment, all will be asked in your entrance examination. For any case of measles, whether it is a new measles or measles within 3 months of age, a single dose of vitamin A should reduce the morbidity and mortality that arises as a result of measles. I repeat, the purpose of giving vitamin A administration in a case of measles is not only to prevent blindness, but also to prevent your what is that? But also to prevent your overall morbidity and mortality. This is a often asked question in your entrance examination. Also, Viva OC we have cleared many things, right? Okay, now what is this? Write a note on etiology, features, and management of rickets. Reference guy, right? So, what do you mean by rickets? You all know that what is the role of a vitamin A? Sorry, vitamin D. The role of vitamin D is to deposit calcium and phosphorus in the growing end. That is mineralization of the growing end. When there is defective absence of vitamin D, defective mineralization leading to mineralization of the growth plates. Defective mineralization of the growth plate. Okay, rickets is a disease of vitamin D deficiency in growing bones, whereas osteomalacia is a disease of vitamin D deficiency in persons who had attained growth. So, rickets is a disease of children, whereas osteomalacia is a disease of vitamin D deficiency in adults. Remember, both are characterized by defective mineralization and both are characterized by diffuse osteoporosis, etc. So, the rickets can be due to either what are all the things that you require? You need calcium, you need phosphorus, you need parathyroid hormone, you need vitamin D. So, any of these things, deficiency of vitamin D, deficiency of calcium, deficiency of vitamin D, deficiency of calcium, in deficiency of phosphorus as well as increase in phosphorus, both can lead to rickets, and then deficiency of parathyroid hormone, all can lead to rickets. So pathophysiology, definitely you will be asked pathophysiology, or what is the method by which vitamin D is absorbed in the body, vitamin D is produced in the body. The first point is ultraviolet B. It is not ultraviolet A. It is ultraviolet B, around 280 to 320 nanometers falls over the skin. Falls over the skin. So that what will happen? The 7-dehydrocholesterol that is present in the skin will be converted to pre-vitamin D3. This pre-vitamin D3 will be converted to 25 hydroxy D3 in liver. I repeat, 25 hydroxy D3 in liver, and this is the storage form. This is the storage form. Storage form of vitamin D. That's why you need to measure 25 hydroxy D3 level in case of nutritional rickets. In case of nutritional rickets, you need to measure 25 hydroxy D3 because it is the storage form. This 25 hydroxy D3 will be converted into 125 dihydroxy D3 in kidney. Will be converted to 125 dihydroxy D3 in the kidney. So 125 OH dihydroxy D3 in the kidney, which is the active form. So what is the role of this vitamin, active form of vitamin D? The role of this 125 dihydroxy D3 is to reabsorb calcium from the renal tubules. You need to absorb calcium from intestine, but also it causes absorption of phosphorus from the proximal renal tubule, absorption of phosphorus from the proximal renal tubule. This 125 dihydroxy D3, the active form of vitamin D, absorbs calcium as well as phosphorus from the intestine as well as proximal convoluted tubule of the kidney. tubule of the kidney, right? Tubule of the kidney. So whenever there is no vitamin D, whenever there is no vitamin D, whenever there is poor sun exposure, whenever there is poor sun exposure, 25 hydroxy D3 formation will be low. And this in turn leads to 125 dihydroxy D3 levels will be low. And it leads to low calcium absorption, low phosphorus absorption, so lead to hypocalcemia and hypophosphatemia. This hypocalcemia in turn triggers parathyroid hormone secretion. This parathyroid hormone causes calcium resorption from bone to neutralize low calcium levels of the body, and but at the same time it causes phosphorus excretion, so it causes hypophosphatemia, and then it converts 21 alpha hydroxylase. It activates 1 alpha hydroxylase, which converts 25 OH-D3 to 125 dihydroxy D3. 125 dihydroxy D3. So as a result of which, what will happen in nutritional rickets? Calcium will be low. At times it can be normal due to bone resorption by parathyroid hormone. Phosphorus will also always be low. Why phosphorus always low? One, due to deficiency of vitamin D. Another due to excess parathyroid hormone, which causes secretion of phosphorus from the proximal renal tubule. Because of that, bone turnover leads to high alkaline phosphate. Leads to high alkaline phosphate. Bone turnover leads to high alkaline phosphate. 3. What are all the other points? There is secondary hyperparathyroidism. There is secondary hyperparathyroidism. Okay, there is secondary hyperparathyroidism. What else? So these are all the things you need to know. Remember, calcium can be normal in case of nutritional rickets. Calcium can be normal. Phosphorus will always be low. Alkaline phosphate will be high. Parathyroid hormone will be high. So this is all about the biochemistry of rickets. What is the investigation of choice? The investigation of choice is 25 OH-D3 levels in the blood. OH-D3 levels in the blood. Okay. What are all the causes for vitamin D deficiency? Usually it is not available much in diet because you need to eat half kg of fish, which is unlikely to occur. Very unlikely. So you rely on sunlight exposure, but majority of us sunlight exposure means it is 11 a.m. to 3 p.m. This is also an entrance question or Viva OC question. 11 a.m. to 3 a.m. 3 p.m. is the time that you need to expose yourself to sunlight. So what will happen if there is poor sunlight, but majority of us are restricted to indoor area between 11 a.m. to 3 p.m. That's why, despite living in an area where you have only hottest climate, still many of us are vitamin D deficient because we are not exposing ourselves properly to sunlight at proper time. You need to expose 30% of your body surface area at least 30 minutes a day for about 5 days a week. For about 5 days a Okay, malabsorption. All fat-soluble vitamins are absorbed in duodenum and jejunum. So when you have celiac disease, which is dealing with the mucosal transport disorder, the mucosa is extremely damaged, as a result of which your fat-soluble vitamins are not absorbed. Second one is liver disease, chronic liver disease, because of the absence of 25 hydroxylase enzyme. And medications such as rifampicin anticonvulsant, it increases cytochrome P450 oxidase, as a result of which the active form of vitamin D will be less. So majority of rickets are mainly due to poor exposure to sunlight. Dietary lack of calcium occurs particularly when some people who do not take any milk at all. Along with vitamin D, you need to take a proper amount of calcium, at least 50 milligram per kilogram per day for about 3 months while you are giving vitamin D supplementation. And again, it can also be due to phosphorus deficiency, usually occurs in case of preterm infants, and this is usually a physiological one. As we discussed already, your vitamin D deficiency usually manifests with tetany. So, with the tetany, one. Second point is hypocalcemia, parathyroid hormone. These are all the things we saw. Parathyroid hormone maintains serum calcium but decreases phosphorus level. So, this hypophosphatemia in turn causes apoptosis of chondrocytes, leading to hypertrophy and swelling at these sites. Let me tell you what are all the findings. Defective mineralization results in generalized osteomalacia or weakening of bone matrix and leads to deformities. So, what are all the diagnostic triads in rickets? Serum calcium will be low, serum phosphorus will be low, serum calcium can be normal also due to secondary parathyroid hormone mediated resorption from the bone. Alkaline phosphate will always be high due to high bone turnover. Vitamin D levels. So less than 10 nanogram per ml is called as deficiency. 10 to 20 nanogram per ml is called as insufficiency, whereas 20 to 60 nanogram per ml is called as normal, and more than 100 nanogram per ml is called as uh, toxicity, is known as toxicity. So less than 10, 10 to 20, 20 to 60, more than 100 is nothing but vitamin D toxicity. What are all the manifestations of vitamin D deficiency? Very, very simple. Fraying. Fraying means irregular borders of the growing end of the bone. Cupping, because of the cupping. Cupping means because of the destruction of the epiphyseal plates here and there. Cupping. And then widening of a metaphyseal area, because there will be no phosphorus induced apoptosis of chondrocytes, as a result of which hypertrophic growth platelet and generalized widening of metaphyseal ends. So cupping, fraying, widening. Remember three points. What are all the points in favor of vitamin D deficiency in bones? Cupping, fraying, widening. So look at the fraying. Look at the fraying. Irregular borders of the ends of the bones is fraying. Cupping means small depression in case of metaphysis is fraying. And then widening of the growing end of the bones. Widening of the growing end of the bones. Cupping, fraying, widening, generalized osteopenia are the manifestations of vitamin D deficiency. So, what are all the manifestations of vitamin D deficiency? 100% this is a question for you. 100% this is a question for you. So, what is this? One is ping pong sensation of the skull. So, that is called craniotapes. That is called craniotapes. So, in and around the sutures, the skeletal calvaria is deformable. That is called craniotapes because of defective mineralization, as well as delayed closure of wide open anterior fontanelle and open posterior fontanelle. Fontanelle usually closes by 1 to 1.5 years, but here it takes some more time in rickets. Second point is posterior fontanelle is closed at birth. When posterior fontanelle is open at birth, apart from hypothyroidism, another cause is hypovitaminosis vitamin D in mothers. That's why it leads to hypovitaminosis in newborn. And then you have severe dental caries, and because of the poor growth, poor deposition of calcium and decreased apoptosis at the growing ends, you will get bleeding of costochondral junction, and it is usually painless. Bleeding of costochondral junction, and it is usually painless, and when it occurs at the junction of thorax and abdomen, we call it as Harrison sulcus. Harrison sulcus. So what is called bow legs? Bow legs means bow legs. Okay. Bow legs means what? Bow legs means okay. Bend knee. It is due to okay genu varum. Knock knee is due to genu valgum. Genu valgum. So and then widened wrist and ankles. Deformity increases whenever any pregnant lady is deficient of vitamin D. There will be deformability of pelvic outlet leading to difficulty or obstructed labor. List deformability. Okay. Another manifestation in children are what is this? Stridor. This is called stridor, and you have hypocalcemic seizures. Whenever any child between 6 months to 5 years is brought with a fever-induced seizure, the next thing that we need to rule out is whether there is an underlying hypocalcemia is there or not. And then because of poor calcium mediated contraction, you will have hypotonia, and all of them leads to failure to thrive, irritability and bone pain. They are more prone for pathological fractures. So epiphysis, metaphysis, cupping, fraying, widening. Cupping, fraying, widening. So these are all the manifestations of vitamin D. They will ask you, apart from that, they will ask you the treatment for vitamin D. So what is the treatment? 2000 international units. I repeat, what is the treatment? They will be asking you. One is less than 1 year, more than 1 year. Less than 1 year, 2000 internationals IU per day. More than 1 year, 3000 international IU per day. How long you need to give? A minimum of 12 weeks. Those 12 weeks it should be supplied by calcium. Calcium how much? 50 milligram per kilogram per day of calcium you need to give. So and then after 12 weeks you need to take an X-ray to look for zone of provisional calcification. Zone of provisional calcification. Okay, zone of provisional calcification. If zone of provisional calcification occurs, change to physiological dose. Change to physiological dose. So what is the physiological dose? Physiological dose is 600 international units per day after 1 year and 400 international units per day before 1 year. 1 year. Sir, I have taken X-ray, but there is no zone of provisional calcification. There is no zone of provisional calcification. Then comes approach to resistant rickets. How to approach this resistant rickets? Let's see. Resistant rickets. Again, approach to resistant rickets is a fascinating question. Very, very easy. It's not that tough. Let me explain you what it is. One second. Okay, now let me tell you what is the approach to resistant rickets. This is very, 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 very important. Approach to resistant rickets. Listen to me carefully. Definitely, this point will fetch you so many marks. Approach to resistant rickets. So, what is the approach to resistant ricket? Zone of provisional calcification at 12 weeks. Then what you need to do? You always need to do PO4 level. So PO4 level low, phosphorus level is low, PO4 level is high. When you have high Phosphorus, either it can be chronic renal failure or it can be hypoparathyroidism or it can be hypoparathyroid. If phosphorus is low, then you need to look for pH. If pH is low, renal tubular. When pH is normal, renal tubular acidosis. When pH is normal, then you need to do parathyroid level. Parathyroid level. So you have high parathyroid and low phosphorus. Low phosphorus. Three things you need to see. One is low 25 OH-D3. That is nutritional rickets. Whereas 125 OH-D3 is low. That is called vitamin D dependent rickets type 1 because of low alpha hydroxylase. Then 125 dihydroxy D3 level high. This is due to receptor mutation for vitamin D. Receptor mutation for vitamin D. So these are all the manifestations of rickets. These are all the approach to rickets. And another point is parathyroid hormone PTH will be normal, but phosphorus is low. Calcium will be normal. So what does it indicate? Whenever hypocalcemia occurs, your parathyroid hormone responds by secretions. Whereas when you have hypophosphatemia, parathyroid hormone will not be secreted and remains the same. This is called hypophosphatemic ricket. This is called hypophosphatemic rickets, characterized by low phosphorus but normal parathyroid hormone level. Very, very important. Again, nutritional rickets. Rickets usually manifest at 6 months to 2 years. Less than 6 months means it is resistant rickets. Resistant ricket means two classification. EDDR 1, in which there is low 125 dihydroxy D3. And then another thing is 125 dihydroxy D3. Levels are very high. This is VDDR type 2. VDDR type 2. This is due to receptor damage. And then rickets that preferentially involves lower limb, preferentially involve girls. And here phosphorus is low, but parathyroid hormone level are high. This is called hypophosphatemic ricket. This is called hypophosphatemic rickets. This is all about an approach to rickets. This is all about an approach to rickets. Very, very important. Very, very important. So rickets. So what are all the questions they will ask you in rickets? As far as the rickets are concerned, whether growing bones or already grown bones. Second point is pathophysiology of vitamin D. Third point is control of vitamin D with respect to serum, calcium, phosphorus and parathyroid hormone. What are all the head to foot manifestations of vitamin D? How you will correct vitamin D? What is the old regimen? What is the new regimen? Old regimen, sorry, I didn't tell you. Old regimen is 6 lakh international units administered intramuscularly, only one dose. Okay, only one dose. Which one? Vitamin D. Vitamin D. 6 lakh international, but later it has been changed to 3 lakh international units. Later it is changed to 1 lakh international units. But majority of them right now, it is, one second, they call. Okay. but majority of them we are using only daily regimen with the help of 2000 international units. One more regimen is called as using 60,000 international units per week for about 6 weeks. This is another vitamin D deficiency management. Vitamin D deficiency management. So right now we have covered an important topic on vitamin A, vitamin D. Then we will discuss about vitamin K deficiency. So vitamin K team. I'm sorry. Okay, so what she is saying, we have one case of recurrent PO. My steno just now at come secretary, he asked me one case of recurrent fever. Okay, each and every time his urine routine turned out to be plenty of puzzles. Each and every time his urine culture turned out to be positive for protease or Klebsiella of more than 1 lakh. So it is a case of recurrent urinary tract infection. Can you tell me what is the most common what is the most common cause for recurrent urinary tract infection? If you say recurrent urinary tract infection is mainly due to vesicoureteric reflux, it is not so. The most common cause for recurrent urinary infection is bladder bowel dysfunction, that is constipation. That is what? Constipation. Okay. Apart from constipation, you have anatomical abnormalities of urogenital tract. That is your bilateral vesicoureteric reflex. That case turned out to be grade 4 vesicoureteric reflex on the right side and grade 5 vesicoureteric reflex on the left side. The child had undergone a bilateral ureteric reimplantation because it is failed because bilateral ureteric reimplantation because it is stage 4 and stage 5 and was not responding to antibiotic prophylaxis, right? So most common cause for, remember, when you need to do an ultrasound, just a simple point. Any non-E. coli UTI, any non-E. coli UTI, you need to take you need to take micturating cystourethrogram, non even the first episode. If it is a E. coli, second episode culture positive urinary tract infection should be investigated again with the micturating cystourethrogram or voiding cystourethrogram, in which vesicoureteric reflex as well as posterior urethral wall can be detected. Can be detected. Now, write a short note of not short note on vitamin K and hemorrhagic disease of newborn. So when someone is asking about vitamin K, remember, two vitamins are not there in the breastfed properly. Okay, the normal vitamin D dosage requirement is 400 international unit less than 1 year. But in new breast milk, it contains only 40 international units per liter. That's why all breastfeeding infants, newborns should be supplemented with 400 international units of vitamin D. 1 ml contains 400 international units. What is vitamin K? In the same way like vitamin D, newborns, your breast milk does not contain adequate vitamin K. As a result of which, all exclusively breastfed infants immediately after delivery should be given a dosage of vitamin K. Okay, 1 milligram for children more than 1000 grams and zero point 0.5 milligram for children less than 1000 grams is mandatory. So when someone is asking question about vitamin K, first write breast milk contain insufficient vitamin K. Second point, so all exclusively breastfed infants should be given single dose of vitamin K, 1 milligram if the child is more than 1000 grams and zero point 0.5 milligram if the child is less than 1000 grams. Okay, So what will happen if there is no vitamin K? You all know that vitamin K is responsible for gamma carboxylation of factors 2, 7, 9, 10. What is that? Gamma carboxylation of factors 2, 7, 9, 10. So when this gamma carboxylation doesn't occur, 2, 7, 9, 10 will be gone, leading to hemorrhagic disease of newborn, leading to bleeding. So what are all the three types of hemorrhagic disease of newborn? There are three types of hemorrhagic disease of newborn. What are all they? Let us see. Okay, done. So what are all the three types of hemorrhagic disease of, one second. Okay, let me add here, add page. Done. So let's see what are all the three types of hemorrhagic disease of newborn. So let me write hemorrhagic disease of newborn. Hemorrhagic disease of newborn. There are three types of hemorrhagic disease of newborn. What are all they? Let's see. There are three types of hemorrhagic disease of newborn. One is early, second one is classic, third one is late onset. Early means manifesting within first day. Classic HDN means 2 days to 7 days. Late onset means more than 7 days. That is bleeding. That is bleeding. The classic hemorrhagic disease of newborn usually due to not giving vitamin K, to not giving vitamin K injection. That is the cause. Whereas early onset hemorrhagic disease of newborn is due to maternal vitamin K deficiency. Due to maternal vitamin K deficiency. Okay, whereas late onset vitamin K deficiency, which occurs after 7 days, is mainly due to neonatal cholestasis. Neonatal cholestasis, as a result of which reduced fat absorbing vitamins. One cause is celiac disease, not celiac. One cause is, what is that? Cystic fibrosis, causing pancreatic insufficiency. One cause is cystic fibrosis. The manifestation of early and classic are usually gingival bleed. What is that? Gingival bleed. Or else it can be due to hematemesis. It can be due to hematemesis. One is gingival bleed, second one is hematemesis. Hematemesis. Third one is umbilical cord bleed. Umbilical cord bleeding after cutting. Okay, whereas your late onset bleeding, which occurs as a result of malabsorption due to pancreatic insufficiency, one cause is cystic fibrosis. Here what happens, the child can get hemopericardium, bleeding at unusual sites, hemopericardium. Also, as well as the most dreaded complication is intracerebral hemorrhage. Dreaded complication is intracerebral hemorrhage. So this is very, very important. So early or late onset HDN is prone to produce intracerebral bleeds. Intracerebral bleeds. Okay. So these are all the three types of HDN. Three types of HDN. Hemorrhagic disease of newborn, various types. You draw the tabular column and enter the points which I had written. You will get put 5 marks. Apart from that, phylla means plant products. Vitamin K derived from plant products. Menaquinone, vitamin K synthesized by intestinal bacteria. Remember, the child immediately after birth will be devoid of intestinal good bacteria or flora. This intestinal flora is responsible for vitamin K production. Vitamin K production. That's why till the intestinal bacteria establishes itself in intestinal tract, your vitamin K will be deficient for the body, so that you are giving vitamin K administration to children exclusively on breastfeeding. And as I told you, you need both bile and pancreatic juice for the absorption of vitamin K. Vitamin K is usually absorbed in jejunum. Okay, it is absorbed along with any fat soluble vitamins are absorbed with with the fats. Absorbed with the fat or chylomicron. Principal site of storage for vitamin K is liver. So classic HTN due to absence of vitamin K producing in the newborn gut. Okay, early onset is due to maternal deficiency, which can be due to administration of anticonvulsant or administration of broad spectrum antibiotic to the mother. Okay, or administration of TB tablets, your rifampicin, etc. So spontaneous bleeding, where are the spontaneous bleeding? What is the dosage of vitamin K is established to you, and what is the management of hemorrhagic disease of newborn? The management of hemorrhagic disease of newborn is very very simple. When you have time, you give injection vitamin K to look for replenishments of 2, 7, 9, 10. When you don't have proper time, so that if you delay giving those clotting factor, the child will ultimately die of intracranial bleed. That's why you need to give vitamin K as well as fresh frozen plasma, which contain 2, 7, 9, 10, along with vitamin K to augment the production or activation of factor secreted by liver. The only clotting factor that is not secreted by liver is factor 8. Factor 8. Right. So, what is the management? The management is injection vitamin K. Second one is fresh frozen plasma. Fresh frozen plasma till the child becomes normal. So far we had discussed about vitamin A, vitamin D, and vitamin uh, K. Vitamin K. Sir, you didn't mention anything on vitamin E. Vitamin E. Can anyone tell me what is the manifestation of vitamin E? So what is the role of vitamin E? Let me write. Vitamin E. What is the manifestation of vitamin E? Remember, vitamin E is an antioxidant. If they ask in short notes, you can write antioxidants. Second point, it reduces oxidation of RBC membrane. Oxidation of RBC membrane. And it helps in myelination. Helps in myelination. Okay, whenever you have diseases like cystic fibrosis, your vitamin E will not be absorbed. What is the manifestation of vitamin E? Preterm hemolysis. That is, spontaneous hemolysis occur in children less than 32 weeks. Preterm hemolysis. And then it also produces ataxia. Unknown ataxia will be given a trial of vitamin E. Vitamin E. Okay, so one is preterm hemolysis, second one is ataxia. Please remember with respect to vitamin E. So A, D, E, K over now C. Now C. So what are all the things that we know before going to see this vitamin C? Let's see. Vitamin C. So vitamin C is nothing but, as you all know, it is nothing but ascorbic acid. Character is, one second. Okay, now vitamin C, the deficiency is otherwise known as scurvy. The deficiency is otherwise known as scurvy. Okay, what is the role of vitamin C? Wound healing. Okay, one is wound healing. Second one is cross linkage of hydroxyprolyl reduce of collagen. Reduce of collagen. Cross linkage, and also it is also an antioxidant. Okay, vitamin C right now, previously we used to get in sailors, but right now we used to get in children with autism. Children with autism. Okay, that is how we see. And the treatment of choice is vitamin C bolus doses or daily physiological dose of under international units. One orange equal to 100 ml of vitamin C. Vitamin C, scurvy. Okay. So let's see what are all the things that it is given here. Okay. So collagen formation, wound healing, bone formation, iron absorption, antioxidant property. Antioxidant property I told you, iron absorption I did not tell you. So vitamin C deficiency can also cause microcytic hypochromic anemia as a result of coexistent iron deficiency. Citrus, those who doesn't eat citrus fruits are prone for the symptoms. The manifestations of vitamin C deficiency are petechiae purpurae or petechiae purpurae pseudo paralysis. Pseudo paralysis means because of the periosteal bleed, the child cannot move his limbs properly. This is called pseudo periosteal, pseudo paralysis of femur. Okay, and then what else you can have? Apart from that, because of the poor wound healing, the child is more prone for bleeding gums, hemarthrosis such as painful joint swellings, peripheral edema, and pseudo paralysis or frog-like posture mainly due to periosteal bleed. Periosteal bleed. Here, scorbutic rosary is a painful one because it causes angular swellings at the costochondral junction, not a smooth one. And also, it causes sternal depression, otherwise known as pectus excavatum. Pectus excavatum. And very very important, cerebral, it can lead to bleeding because of poor vessel. It can lead to bleeding causing cerebral hemorrhage and also causing hemopericardium. There are four radiological signs of vitamin C deficiency. There are four radiological signs of vitamin D deficiency. In the same way, there are four manifestations of vitamin D deficiency. They are: one is the epiphysis around it will be a thick margin, that is called what is that called? That is called Wimberger sign. And also the growing end will have some serrated tips or margin, and it is called Pilken spur. Okay, Pilken spur. Okay, Pilken spur and Pilken spur. And below the epiphysis, there is a zone of metaphyseal density that is called Trummer-Feld zone. And on other side, it is called white line of Frankel. White line of Frankel. Okay, white line of Frankel. So Wimberger sign is rimmed epiphysis. White line of Frankel is nothing but radio dense area in the metaphysis. Small dots or holes in the metaphyseal region is called as Trummer-Feld zone. Periosteal elevation often occurs due to subperiosteal hematoma. That's why you get frog-leg sign. Frog-leg sign. Okay. What are all the X-ray finding? White line of Frankel, Wilken spurs, ground glass, everything was discussed. Okay, so that we have discussed about water soluble and fat soluble vitamin. Let me write certain things on B complex vitamin, so that let me see before drinking tea how many of you are going to answer correctly. Let's start. Let me write. Wait. At page So let me write one by one. Which vitamin A deficiency leads to hyper segmented neutrophils? Okay, I'm extremely sorry. Hyper segmented neutrophils. Let me write. So I'm sorry. One is hyper segmented neutrophils. Elevated methylmalonic acid. Elevated homocysteine but normal methylmalonic acid. Okay, and then where you will use, which vitamin you will use? Maple syrup urine disease. Beriberi is caused by maize eating population. Which vitamin deficiency? Maize eating population. Which vitamin occurs as a deficiency occur as a result of giving polished rice? Polished rice. Angular cheilitis is caused by. Angular cheilitis is caused by. And then the triad of what? Diarrhea, dermatitis, dementia. Where you will get burning fit syndrome. Burning fit syndrome. Where you will get alopecia and developmental delay. Alopecia and developmental delay. Which vitamin is associated with the egg? Avidin. So that when you boil the egg, you will get a good vitamin D. Hypersegmented neutrophils occurs in both B12 and folate. B12 and folate. Elevated methylmalonic aciduria in B12 because methylmalonyl CoA is converted into succinyl CoA by B12. So in B12 deficiency, methylmalonic acid will be high. Both homocysteine and normal is folate deficiency. Maple syrup urine disease is caused, can be managed with thiamine because that branched ketolase depends on thiamine as a cofactor. Wet berry thiamine. Maize eating population pellagra, which is characterized by diarrhea, dermatitis, and dementia. Okay, polished rice more prone for B1 or thiamine deficiency. Angular cheilitis is due to riboflavin deficiency. Burning fit syndrome is due to pantothenic acid deficiency. Alopecia and developmental delay is due to biotin deficiency. The avidin present in the egg binds biotin and cause biotin deficiency. And pyridoxine B6 is useful for homocystinuria. And also it reduces seizures in newborn. Reduces seizures in newborn because it is a cofactor for GABA. GABA is an inhibitory neurotransmitter. So this is about B soluble vitamins. So fat soluble, water soluble over. Now let's talk about severe acute malnutrition. Right. Define severe acute malnutrition. Define. They will be asking you define. Weight for height less than the standard deviation. 1. The standard deviation. Second one is bipedal edema. Third one is mid upper arm circumference less than 11.5 cm. This is called severe acute malnutrition, right? This severe acute malnutrition can be again divided into whether it is complicated or uncomplicated. Complicated means along with some you have hypothermia, hypoglycemia, infection. This is a deadly triad. Bipedal edema because it can be a manifestation of kwashiorkor in which mental lethargy and poor appetite will be there, leading to further increase in morbidity and mortality. Okay, hypoglycemia, okay, infection, and then hypothermia. So when you have medical complications, you will call it as, when you have medical complications, you have this complicated. Uncomplicated means there is no edema, there is no medical complication. This can be dealt with supervised home regimen, supervised home treatment without complication. With complication means inpatient patient, and it spans over 8 weeks. First 2 weeks treat complication, that is stabilization phase. Next 6 weeks maintenance. Nutrition should be given importance. Nutrition should be given importance. Okay. Severe acute malnutrition 6 months to 6 years. Weight for height less than 3 standard deviation. Bipedal edema mid upper arm circumference less than 11.5. Remember, when you have medical complication, when you have one or more danger signs of IMNCI, when you have severe edema, low appetite, it comes under complication. It should be treated in hospital, whereas uncomplicated can be treated at home. Okay, so very simple. Uncomplicated SAM or moderate acute malnutrition can be treated at home itself by giving 150 kilocalories. How much? 150 kilocalories per kilogram per day, along with the ready to use therapeutic feeds. Ready to therapeutic feeds are having reduced water content, and it can be mixed with the water and to make it as a paste, and it can be eaten. There are so many health mixes. One famous health mix in Chennai is Manna health mix. That is nothing but ready to eat therapeutic food that can be used to treat the condition because they are protein rich and then energy rich. They are protein rich and energy rich. Other treatments are single dose of albendazole, amoxicillin 5 days, vitamin A, as well as iron treatment if it is required. And what is this sensory stimulation? It doesn't mean that you can treat your severe acute malnutrition children only with the medicines. They also need tender loving care in the form of structured physical activity, in the form of structured playful activity. Okay, apart from that, twice a week your auxiliary nursing midwife or multi-purpose health worker will go and visit the child, whether the child had put on weight or not. Who are all the people going to visit? Asha people, Anganwadi, and then ANM means auxiliary nursing midwife. Okay, what are all the 10 points? What are all the 10 points you need to see while treating a case of severe acute malnutrition? Hypoglycemia, hypothermia, dehydration, hypoglycemia, hypothermia, dehydration, infection, deadly trial. Hypoglycemia, hypothermia, infection, and then dehydration, electrolytic imbalances, and micronutrient deficiencies. Micronutrient deficiency means zinc and copper. Electrolytes means mainly potassium and bicarb. Initiate feeding with the F75 formula. What is called F75 formula? 100 ml contains 75 kilocalories. And then for catch up growth, F100 formula, in which giving 100 kilocalories. Per 100 ml contains 100 kilocalories. Sensory stimulation, as I told you, tender loving care. Loving care. So, what do you mean by that tender loving care? In stabilization phase, treat infection, treat hypothermia, treat electrolytic disturbances, treat infections, etc. Please remember one thing, never ever start iron, never ever start iron in the stabilization phase. Iron in the stabilization phase, because iron can lead to increased growth of E. coli, which can lead to sepsis. Lead to sepsis. Okay, so what else? Stabilization phase usually lasts for about 1 week, not even 2 week, 1 week. From 2 weeks to 6 weeks, it is nutritional rehabilitation. First week, you are stabilizing the child by treating the complications. Second phase, you are giving nutritional support to the child. Sensory stimulation as usual. Remember, what is called hypoglycemia? Hypoglycemia is defined as a blood sugar of less than 54 milligram per deciliter, usually associated with hypothermia and infection. If they are asymptomatic, you can give NG, you can give 50 ml of 10% dextrose via nasogastric tube, or else you can give 5 ml per kg of 10% dextrose through nasogastric tube or IV, and then followed by F75 formula every 2 hours. That means F75 formula 6 o'clock means 10% dextrose will be given at 8 o'clock. So in that way, again 10 o'clock F75 formula, 12 o'clock, yeah, 12 o'clock you can use ready to use therapeutic food. So high energy formula at 1 hour, and then after 2 hours ready to use therapeutic foods. Okay, so you are giving 50 ml of 10% dextrose or 5 ml per kg of 10% dextrose. Hypothermia is managed with the help of gloves, gulla, socks, and mittens. Severe hypothermia means less than 35.5, whereas severe hypothermia means rectal temperature less than 35.5 degrees Celsius or axillary temperature less than 35 degrees Celsius. So, what is the treatment of? So, what is the treatment? Let's see. So, tender loving care, avoid rapid rewarming, immediate feeding, antibiotics, prevention, skin to skin contact should be seen. Okay, every 2 hours F75 formula, and then your, what is that? Formula fits can be given. Dehydration. So hypothermia. Okay, dehydration means you need to correct dehydration. In case of severe dehydration and severe acute malnutrition, you will give 15 ml per kg. You give 15 ml per kg over 4 hours. Over 15 ml per kg over 4 hours. If it doesn't respond, another 50 ml per kg over 4 hours. If doesn't respond. Okay, if it doesn't respond, you need to consider shock, and you need to consider sepsis. You need to consider IV antibiotic. Okay, so initially I told you F75 formula, which contains 100 ml contains 75 kilocalories. Why F75 formula? Because high nutrition should not be given to the baby in the first stabilization phase. When you give high quality protein, it will lead to nutritional recovery syndrome like that. Okay, that's why you need to monitor closely for overhydration. Along with that, always take ORS 5 to 10 ml per kg. So F75 formula till potassium supplementation, and by about 2 weeks you can add potassium supplementation 4 milli equivalent per kilogram per day. two things that should be given importance first. One is magnesium, another is potassium. Those things are very, very low in cases associated with chronic malabsorption or diarrhea. In those cases, you need to give plenty of importance to electrolytes. Always try to avoid serum sodium. Try to avoid serum sodium. In some children, they are more prone for gram-negative bacilli, such as Pseudomonas, okay, E. coli, etc. These are all gram-negative organisms that produce profound death. So all can be prevented by taking proper hand wash, and hand should be cleaned. 6-point method, hand should be cleaned periodically. Measles vaccine is mandatory after the child attains 6 years of age. Apart from that, what else you will give in consolidation or maintenance phase? Vitamin A, zinc, folic acid, copper, iron also. Okay, during stabilization phase. So initially, as I told you, F75 formula, then followed by F100 formula, then complementary phase. Structured physical play, not giving mobile phone. Structured physical play for about an hour per day for 1 week. Okay, then what is called, you have treated the child, what is called primary failure and what is called secondary failure. Primary failure is absence of edema to disappear by day 4. Absence of to regain weight is by day 4. That is primary failure. Apart from that, presence of edema at 10 years and failure to gain at least 5 gram per kilogram per day by about 10 years. Secondary failure means initially during the stabilization phase and maintenance phase, the child will be normal, but after some point of time, the child will fail to gain 5 gram per kilogram per day. 5 gram per kilogram per day. So this is called secondary failure. Primary failure means failure to gain 5 gram per kilogram per day by day 10. Second, this one is failure to gain weight by about in after during stabilization phase. Okay, initially weight gain will be more than 5 gram per kilogram per day in the first 10 days. After 10 days, if the failure to gain weight occurs, then it is called secondary failure. The most common cause for secondary failure is tuberculosis. You need to rule out underlying tuberculosis. Underlying tuberculosis. Which one? When you underlying tuberculosis should be thought of when your secondary failure occurs. Primary failure means there must be some problem with respect to F75 and F100 formula. What is called marasmus? The main single point for marasmus is energy loss, subcutaneous fat loss leading to monkey faces and baggy pant appearance. Monkey faces and baggy pant appearance in case of marasmus. Marasmus is due to energy deficiency, triglyceride or fatty content deficiency. Whereas kwashiorkor is caused by hypoalbuminemia, hepatomegaly, lethargy, and refusal of feeds. Refusal of feeds here because of poor protein, there is flaky paint dermatosis. What is that? Flakes of skin will fall off. That is called flaky paint dermatosis. And alternative pigmentation and depigmentation of hair growth will be seen. That is called flax sign. So monkey back and then baggy pant and monkey faces is for marasmus, whereas flaky paint dermatosis and flax sign is a manifestation of skin in severe acute malnutrition. So that is what they have been writing. So severely wasted kwashiorkor edematous weight gain, that is not normal weight gain. So here wasting of fat and muscles, here people will be there to take care of him. Edema is a manifestation of kwashiorkor. Skin changes are a manifestation of kwashiorkor. Hair changes are a manifestation of kwashiorkor. Okay, whereas appetite will be good, alertness will be good, recovery will be good in case of marasmic. In a case of marasmus, severe acute malnutrition. Severe acute malnutrition. Look at this. Look at this. What is this? Look at this. This is monkey faces. This is baggy pant appearance. These are all the cases that come to my clinic. So what is this? This is called flaky paint dermatosis, and this is alternative pigmentation and hypopigmentation, otherwise known as flax sign. Pigmentation occurs during stages of giving nutrition. Depigmentation occurs during stages of poor appetite. This is called flaky paint dermatosis or flax sign, right? So these are all the, what are all the other things that you need to know? Gastrointestinal symptoms. Yes, in case of marasmus, because of the poor absorption, you will get bulky stools, which in turn broken down by intestinal bacteria, leading to acidic stools. Whereas in case of kwashiorkor, you will get unabsorbed sugar, which in turn acted upon by the intestinal bacteria to produce gas. There will be neurological manifestations like tremor in nutritional recovery syndrome if it is associated with kwashiorkor. Cardiovascular system is characterized by bradycardia in case of marasmus and hypotension in case of kwashiorkor. Renal function is decreased GFR in case of marasmus and diminished GFR along with aminoaciduria, glycosuria in case of kwashiorkor. So these are all the manifestations of kwashiorkor and marasmus. Manifestations of kwashiorkor and marasmus. Severe acute malnutrition is definitely an important question for you. Another likely question is what is called wasting and stunting. What is called wasting? Wasting means you have low weight for height. What is called stunting? Stunting is low height for age. Wasting indicates acute malnutrition. Stunting indicates chronic malnutrition. When you have reduced weight for age, reduced means it is acute on chronic malnutrition. It is due to acute on chronic malnutrition. Then finally, the topic for today is breast milk. The topic for today is breast milk compared to what is the duration of exclusive breastfeeding. Exclusive breastfeeding means you are giving breast milk. Up to 6 months. Only breast milk up to 6 months. Exclusive breast milk also includes ORS. Exclusive breast milk always includes ORS. ORS. One exclusive breastfeeding also includes vitamin supplements. Also includes vitamin supplements. Remember, giving ORS and giving vitamin supplements doesn't mean that it is not a case of exclusive breastfeeding. It includes exclusive breastfeeding. So weaning should be started after 6 months. Should be started after 6 months. What is the difference between breast milk and cow milk? Breast milk contain high lactose. Okay, high lactose, which supports energy needs, everything, calcium absorption as well as gut flora will be increased. This is so high carbohydrate, high lactose, easily digestible sugar with respect to breast milk, whereas cow milk contain more of proteins compared to breast milk, and these proteins, low total proteins compared to cow milk, and easily digestible lactalbumin and lactoferrin along with the taurine and cysteine for brain development, whereas fat remains the same. So carbohydrate more in case of breast milk, protein more in case of cow milk, but more of casein compared to whey protein. Whey protein, WHO protein is good for health. This whey protein, even though the total protein is less in breast milk, whey protein is more in breast milk compared to cow milk. So it is easily biodigestible and easily absorbable. Fat remains the same in both breast milk and cow milk. Mainly it contains omega 3 and omega 6 fatty acids. Vitamins includes all vitamins A, D, E, K, but K you need to give one single dose. D you need to give 1 year administration of vitamin A for all exclusively breastfed infants. Along with that, immunological factors like secretory immunoglobulin, lactoferrin binds iron so that it will not be available for E. coli, so that sepsis can be prevented. Lysozyme present in the saliva protect against so many organisms. So many organisms. So what are all the benefits of breast milk? The benefits of breast milk, one is nutritional support. Whatever that is low, they are highly bioavailable so that brain and vision can be utilized to the fullest core. Immune protection by means of lysozyme, lactoferrin, macrophages, and secretory immunoglobulin. That's why breastfed babies are 14 times less likely to die of diarrhea because of the tremendous presence of immunoglobulins. Reduced risk of chronic diseases such as diabetes, allergy, asthma, rare diseases, etc., heart diseases, etc. High IQ because of the presence of DHA in breast milk, and then very low incidence of sudden infant death syndrome. Very low incident of sudden infant death syndrome for mothers. They are more prone for rapid recovery. They are less likely to have postpartum hemorrhage. And remember, by giving lactation, your prolactin will be more. Prolactin inhibits the production of gonadotropin, so that you are, by giving breast milk, you are protecting the mother from getting pregnant again. Low risk of breast cancer and ovarian cancer. Weight loss is faster in case of mothers who breastfed their child. And then emotional bonding, as we always say. Emotional bonding, as we always say. Remember, first 3 days of breast milk is called as colostrum. Then they will be asking these 5 points. First 3 days of breast milk is called colostrum. They are poor in nutrition but rich in immunoglobulin, vitamin, and protein. This is the nature's first vaccination is colostrum. Nature's first vaccination is colostrum. Transitional milk is between 3 to 14 days, which is higher in fat and lactose. Again, after 2 weeks, you will get proper mature milk, which is a very good combination of immunity, lactose, fat, etc. Any child, mother who is less than 37 weeks, the breast milk of those mothers who gave birth to preterm are called as preterm milk. This preterm milk is rich in protein and calorie content. Fore milk, the first part of the milk is called fore milk, which contains only water. Whereas the second part of the milk, which contains nutrition. When you give only fore milk, you will be satisfying the appetite, you will be satisfying the thirst but not satisfying the appetite, leading on to poor weight gain in fore milk syndrome. That's why you need to empty one breast, again then you come to another breast. If you keep on diverting between two breasts before completion of entire sucking of one breast, you will get fore milk syndrome, in which even though you give adequate breast milk, you are unlikely to have a good weight gain because you are satisfying only the thirst but not the appetite. Positioning, so you need to, mother should sit comfortably with their back support. Both hands should support the baby. And remember, baby nose is at the level of the nipple. Baby's nose is at the level of the nipple. What is called proper latching? What is called proper latching? You should wide open mouth, wide open mouth. Second one is upper part of the areola should be visible. Third one is chin should be against the breast of the mother. Third one is lower lip should be completely everted. Lower lip should be completely everted. So effective suckling, always it is a so slow rhythmic suckling with pauses in between. And as I told you already, empty one breast first, then switch to another breast to get both fore milk and eye milk. If not, you will give only fore milk, leading on to so many problems. What are all the other problems? Sore nipples, engorgement, mastitis, all can be treated by continuing breast milk. And you can apply breast milk over the, you can give breast milk, you can apply breast milk over the sore nipples. Apply breast milk over the sore nipples. Apply the sore nipples. And then proper lactation counseling. And then for inverted nipples, you can use inverted syringing technique. For inverted nipples, you can use syringing techniques. Syringing techniques. Technique. What is called expressed breast milk? Expressed breast milk. Okay, mother who cannot give breast milk directly to them, they need to express, keep it in the fridge, and they can give. That is called an expressed breast milk. Always it should be expressed in a wide mouth container. How long you can keep that breast milk? In room temperature 6 degrees Celsius, in fridge 2 to 8 degrees Celsius for 24 hours, and in refrigerator freezer minus 20 degree for about 3 months. Okay, so with this, we have completed our session today. Hope we meet for further sessions tomorrow by sharp 6 p.m. Okay, thanks a lot. And what are all the topics? The topics for tomorrow will be growth and development. Bye bye for now.